I'm here to kind of give the voice of the physician to this, and having practiced in the field of pain medicine, which the time I started my clinical practice in 1983, it was not even a real subspecialty at that point. And I started right across the street downtown as an anesthesiologist here, right out of my residency. And Dr. Gostein, my partner, and I saw that we were going to be doing pain medicine, and we had a vision for a model of care for this. So over the ensuing years, we developed our pain practice, and after several years, we moved completely into pain medicine by 1988. So over the next 28, 29 years, our practice has gradually been refined, and a lot of the things I'll talk about are really done because of physician need. Everything that we've done in our practice has been done because we needed to do it. As practicing physicians, we said, hey, we need to do this. The first thing that when Mark and I started growing, we got beyond 3 people in the group and got to 4. With 2 or 3 people in the group, you can have your little conferences right there in the break room, but when you get bigger than that, you start going to different places, you need to start being organized. And that's when we realized we had to build somewhat of an organizational structure. And the first thing we did, the idea was taking over and doing our own billing and getting our own staff rather than farming everything out like we did in anesthesiology. And so we started understanding that we had to get control over the services that support our practice. That was one of the things, and that's when we started the idea of developing our own management services entity. And that's where ProCare came from, because that's what's emerged out of this. And my medical practice over the years, as we grew and added doctors and consolidated, we constantly had to prove that what we did mattered, that pain was a legitimate thing to treat, that our treatments were reasonable. And then after becoming very organized, we moved from the hospital setting to the community-based setting in an office. And the idea was all the way along, the one thing Mark and I learned about Grand Rapids is that it's a very economically budget-conscious community. And we looked at every single thing in our practice as how can we do it the Grand Rapids way, which is less expensive and keeping the quality up. Because that's the one thing we have in this town is we have generally overall good quality care, and everybody tries to keep the price down compared to other places I've been in the country. So we've taken procedures that we saw that were being done in an expensive way and learned to do them cheaper, outpatient, moved our practice to the office-based setting because it was less expensive to do all of our treatments in an office rather than in a hospital setting with the extra layers of charges. So all that led to the evolution of our practice, doing everything as efficiently as we could, and that's what our management structure followed as we developed the management side of our practice and started doing consulting work with other practices that were just emerging at that time in the early to mid-90s. And as our practice grew, we now have 14 pain physicians and 7 clinics in the area, and ProCare manages that practice, but ProCare also manages 4 other pain practices around the state, plus other specialty practices like psychiatry and neurosurgery and endocrinology. And so we've learned a lot about what does it take to help doctors be very efficient, and we look at every little thing, and I think Tim will talk a little bit more about that. But as the practice grew, one of the other things that we had to demonstrate from our perspective was the fact that we are not able as doctors to understand all the nuances, just like you just heard, that you have to have specialists do the work. Just like we're specialists and do our medical work in a specialty way, your practice support people have to be specialized, which is why as our management team grew, we could acquire specialists in finance, specialists in business development, specialists in office design and recruiting and managing the practice, the idea of understanding the rules and regulations, human resources. We manage over 350 employees around the state. So we have the idea of having these resources in-house makes it a lot easier for us, and that facilitated our growth. As we got growing, we realized also we had to prove that what we did mattered, which is why we got into the idea of measuring the clinical outcomes of our care. And we've been in that since the mid to late 1990s with a project done by the American Academy of Pain Medicine that at that time didn't work, but we kept the ball rolling and developed our own system. So by the early 2000s, we had our own outcomes tool. And by the mid-2000s, technology had caught up to make it easier. The fact that it's web-based and it's done by patients entering their data directly on an iPad in the office waiting room. So technology increasing, letting us do this, collect the data and process it more easily, refining the tool that we use. And that outcomes tool has now gotten to the point where we have outcomes data on up to 4 years of outcomes on 35,000 pain patients, and we have close to 100,000 in unique data sets on those patients, which makes us the largest registry for pain outcomes data outside the federal government that I'm aware of. And we take that data and we've been using it because we analyze it in real time. When the patients fill out the assessments in the waiting room, the data, and it measures their whole life. What we do, you know, as a specialty, say we're treating a back problem, we have to say, well, what does that back problem do to your whole life? And what do the treatments we do affect your whole life? How is what we do making your life better, not just your back better? So it's a very generalized set of questions, including quality of life, patient satisfaction, that we get instantly. It's analyzed and it's put onto a summary page that looks like a lab report, because our doctors need to see something that looks familiar to them. They don't have a lot of time to waste. We summarize a number of different health dimensions into one summary page that you can see the original, the most recent, the trend, and we have color coding abnormal findings, just like a lab report. And our doctors then can see that, and right there when the patient's in the room, we can address trends, behavioral health issues, physical, functional issues. If there's a decrease in patient satisfaction, we see that right there in the clinic when the patient's there, not waiting 3 months for the next Press Ganey survey to come back that doesn't give you targeted data on each patient. So the outcomes tool is used obviously to measure the effects of what we do clinically, but also to help with treatment decisions. We call that data-informed decision-making, and it helps us address the whole person as we're addressing the anatomical structure in the back that's causing the problem. So we have this unique way of using the data in real time as a care management tool, as well as looking backward and seeing what treatments work. And like one of the things we found, we just did a study on spinal stenosis, and we found retrospectively that a lesser expensive treatment, a simple epidural injection, works better with physical therapy than a selective nerve root injection, which is a little more targeted treatment, a little more expensive. And we found that physical therapy is very important and intervening with the pain is important to get the best results. But we found that the less expensive treatment works a little bit better. So it helps our doctors learn from what we're doing and kind of move towards the idea of shifting towards the idea of best practice. And it's based on our own data. Now, it's not absolute, but it's trends and it's statistical differences that give you an idea and a way to go. So as we were developing this, we see all the changes occurring in healthcare with the reorganization of healthcare delivery systems and the onset and the development of organized systems of care, the ACOs, the community-based OSCs that are coming. And one of the things that we found in private practice that's very important is how do we justify our existence? How do we live in this world where we're constantly up against these larger integrated systems? And there's a couple ways that we're accomplishing that. The first way is to have data to show that what we do matters and it really helps the patients. That's not unique, that's not something that everybody has. And we've collected this data, we use it in a meaningful way to not only drive quality care, but to look at value-based care, which is the confluence of cost and quality, where we find what things work the best at the lowest cost. And we take that information to the payers. They're very interested in talking with us. Even the big payer that has their own cadre of providers is very interested in working with us to develop strategies for best value care. And so it's given us a way to work competitively with the larger groups in town that aren't part of us. And we're able to still have a seat at the table with the insurance companies because we actually measure what we do. The other thing that we're doing is understanding what it takes to bring new doctors in the practice, the generational changes and what brings a doctor to a private practice. What is it that a doctor wants now? And it's not necessarily the same values we had 35 years ago. So understanding the changes in demographics helps us recruit, and we've been doing a good job recruiting for our practices around the state because we understand what the younger doctors want. They want to practice in a good environment. They want to feel needed and wanted. They don't necessarily need, or they don't necessarily want to own bricks and mortar, but they do want to feel that they're part of something that addresses them and helps them deliver the best care to the patients. Because we do a lot of teaching with the residents and students here, and I'm learning they're excellent people. They're very dedicated to doing a good job, but they don't necessarily want to own bricks and mortar, but they want to feel relevant. And they don't feel relevant if they're part of a huge entity to which they're just a line item. So we're actually seeing people that bounce out of the big hospital-owned practices where you have to go to 6 committees to get another C-arm for your room, even though you're way behind on patients, because we can address your needs very quickly in our environment, and we base it on the needs that we have. So there's this idea of more rapid turnaround decision-making, the idea of understanding what the younger doctors want, so we create a legacy, so when a doctor leaves, another doctor comes and takes over that part of the practice, there's something to carry forward, and that doctor gets something back for what he invested in all those years. The other thing is that we focus on providing superior care, because that's the one thing that everybody in this room can do differently than when you're being managed by somebody that you don't even know, that's working in a building that you don't even know where that building is, and they're telling you that you got to see 14 patients an hour, and you've got to do this, and you got to ask them for when you can go on vacation or when you can have your lunch break. What we can do in our environment is we create the most optimal patient care environment that focuses on the needs of the patient and providing superior care, and getting our arms around that patient in a private way is something that is valued by our patients, and they don't like the alternatives. And so as we see these emerging organized systems of care, it's our feeling that we're going to see a kind of a backlash by people that want the private practice alternative. And you see this, I spent part of the year in Sarasota, Florida, and we see a lot of that down there. There's a lot of concierge level medicine going on that's thriving. Some of the finest doctors in town that were the heads of the big groups have now gone out of those big groups and are starting their own concierge level practices, and they're very happy, they're very successful, and they have a more gratifying career. So there are options, and I think just to remember, just at a macro level, for all the Walmarts that are doing well, Tiffany's is doing well too, but you have to provide something that that you don't have at Walmart. And you got to focus on the customer, focus on providing a superior level of treatment and outcome, and embracing that patient in a way that they can't get in a more generalized environment in a larger institution. But I think the future's not as bleak, as you'd think. I think there's a lot of opportunities for specialists and private practice primary care doctors to do very well, but it's a matter of getting organized, having the right team of management help to be able to give the specialty management services that you need, be able to cut every ounce of waste out of your practice and focus your resources on providing it for the patients and the best treatments that you can give, and giving the doctors the best information they can get so they can make the best treatment decisions, and sharing that with your constituents. So I appreciate the chance to talk to everybody, and I'm happy to take any questions after the presentation.